Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast I'm joined by our deputy editor Nick Bostock to discuss some of the key news stories affecting general practice. Coming up, we're talking about the GP contract in England, where it could go next and what the BMA, the government and NHS England might all be hoping to achieve. We'll also be discussing the additional roles reimbursement scheme and what could happen with the GP jobs that have been added to that. Later on, we'll be talking about physician associates and the RCGP's decision to say there's no role for PAs in general practice, and its new guidance on scope of practice, induction and supervision for existing PAs, and asking what all of this means for the future. And we're talking about assisted dying. And finally, our good news story this week is about improvements in patients' experiences of contacting their practice. First up today, we're going to be talking about the GP contract in England and some stories we've written that may provide a bit of an indication of where things could be heading, or at least where some of the key players in negotiations would like things to be heading. So Nick, first up, the BMA last week released details of what it would take in terms of a funding increase for general practice for it to call a halt to collective action. What exactly did it say?
The main ask from the BMA is a significant increase in core funding for GP practices in next year's contract. The BMA England GP Committee says it wants to see funding per weighted patient rise from £112.50 in the current financial year to £152.50 next year. So that's a £40 per patient increase in funding, 35% more than the current level. And the BMA wants to see that kick in from next April. As you touched on, the BMA says an uplift on that scale, and this is along with some other longer-term promises from government that it wants to see, would be a first step towards the profession stopping collective action. So it sounds like a big demand, but it's important to put it in perspective. And under this year's contract, core funding for general practice has risen by 7.4% in the end, as a combination of the previous government's miserly uplift that was a big part of pushing GPs towards collective action, and a top-up awarded by the current government after advice from the DDRB, the review body that advises the government on pay for doctors. But even after this year's uplift, the BMA says general practice funding is still more than £350 million down in real terms compared with 5 years ago. And heading into talks on the contract for this year, the BMA was arguing that GP funding has been eroded by more than 50% in real terms over the past decade and a half. So in that context, the extra £40 per patient isn't so outlandish. It's just a step towards restoring general practice funding to a level it was at previously. We know too that the headline 7.4% global sum rise this year won't be enough to deliver anything like a 6% increase in pay for most GP partners, according to financial experts, and that many partners are therefore receiving pay increases well below the level recommended by the DDRB for this year, in a year when pay awards far above this have been awarded to both hospital consultants and to resident doctors. The Health and Social Care Secretary, Wes Streeting, said at the RCGP conference this month that GPs should stop collective action and that it was putting patients at risk. But the response from the GP committee was that many practices are taking these steps like limiting daily appointments per GP to a safe level and dropping unfunded work to try to maintain safety for themselves and their patients by trying to control their workload. Practices are underfunded and overstretched, and they need a solution now, not further down the track. So collective action is about taking control of their situation within the bounds of their contract. Extra money, if it comes next year, as the BMA is asking, might help practices address that workload pressure in a different way by hiring more GPs and expanding the range of services they offer rather than having to limit what they do in the way they're having to at the moment.
That's really sensible points they're making there, isn't it? But I mean, that call for extra funding was in a BMA document called Patients First, Why General Practice is Broken and How We Can Fix It. That document also called on the government to commit to negotiating a totally new GP contract. You know, we're talking about a complete overhaul, sort of on the scale of the 2004 contract, aren't we here? And the BMA put forward in that document a framework for what that contract, or rather what the negotiations for that contract could look like. When would the BMA be aiming for this to happen, and what does it actually want?
One of the annexes to the BMA report is a proposed heads of terms document, basically something that sets out a proposed list of shared aims that the BMA would like NHS England and the government to sign up to as a basis for negotiations over a major reform of the GP contract. So about a year ago, the BMA England GP Committee Chair, Dr. Katie Bramall-Stainer, said that it could take a couple of years to negotiate what she called a wholesale new contract for a generation. She compared the level of change she wants to see from that contract to the 2004 new GMS contract, which you just talked about. And that was the deal that brought in things like the Quality and Outcomes Framework, the QOF, and the current Carr-Hill funding formula. And she compared it also to change on the level of the creation of the so-called Red Book contract, which was the one that came before that 2004 deal. So Dr. Bramall-Stainer wants to see a new contract for general practice, not just one of the annual minor changes to funding and shifting a few targets here and there, but a major reform in time for 2028. So what might it look like? This document isn't a detailed guide, as you mentioned. It's not going to tell you precisely how the contract might shape up, but it sets these broad aims that give a sense of the future the BMA wants. One of the big steps from a funding point of view is a call for sustained annual investment in general practice. One of the big flaws with a 5-year GP contract that ran from 2019 to the start of this year was that there was no mechanism to make sure annual uplifts to practice funding reflected costs or rising inflation. And that's something the BMA is hoping to correct. So it wants an appropriate measure to take account of annual cost inflation built into the contract. The BMA also wants more legal and financial protection for practice to try to strip away some of the risks that can put GPs off taking up partnership roles. So something to revive partnerships to help bring in a new generation of GPs into these roles. And the BMA wants a commitment to invest in safer, modern and green infrastructure in general practice, ensuring they're equipped with modern premises, facilities and technology. And it also wants a move to direct reimbursement of all charges, maintenance and improvement costs around GP premises. So again, that's something that's been a big burden for practices. And the proposal also calls for an agreement that the contract should prioritise continuity of care over hitting activity targets, and that it should enable practice to work collaboratively, particularly for vulnerable and hard-to-reach patients, and that it should look to reduce bureaucracy.
Yeah, there's a lot of stuff there, isn't there? And a lot of those issues are things that are real problems for practices at the minute. I mean, particularly premises. I mean, I think we'll be waiting, hopefully, to see some sort of sign that there might be some capital investment into GP premises at some point under this new government. But in terms of all of those BMA asks, I mean, how likely do you think all of this is? Do you think we're looking at a really major contract overhaul for around 2028, regardless of whether or not all of these things that the BMA are calling for are actually in it?
There's lots in what the BMA is asking for that's very much aligned with what the current government says it wants to deliver. The targets are broadly aimed at restoring the family doctor, building in continuity, supporting practice to work together, cutting bureaucracy. That all looks like potentially safe territory for agreement, some common ground between the BMA GP committee and the government. An obvious point to make, though, is that the money will be the hard part. Premises upgrades, for example. We know the RCGP has called for at least £2 billion worth of investment in GP premises, and we understand the BMA may be looking for a substantially larger figure than that. So will the government sign up to the kinds of premises investment GPs need at a time when it's made very clear that public finances are tight? Workforce too, that the BMA wants a long-term commitment to bring down the current ratio of 2,300 patients per fully qualified GP to just 1,000 by 2040. That will require recruiting and retaining a lot of GPs over the next decade and a half, and that also means money. Another factor is that general practice isn't looking likely to back down on collective action at the moment. The GP committee says practices, like I mentioned, don't have much choice but to take unilateral action because they're under unsustainable pressure right now and they can't wait for plans that might offer some help to materialise further down the track. And the fact that practices are taking this action, even though it basically involves steps like adopting BMA safe working advice and dropping unfunded work that the BMA has been saying for years that practices should do, well before any talk of collective action ever came up. The fact that practices are doing this now under the new government is clearly winding up the Health and Social Care Secretary. And he says he doesn't understand why practices want to give this government a kicking. The fact is they don't necessarily. They just want to take control of their workload. But nonetheless, this could make for a tough environment for negotiating a big new contract. Having said all that, Labour will want to show progress on its big aims, restoring the family doctor, building a neighbourhood NHS, and the BMA is up for working with the government to do that. There are a lot of shared goals, and the BMA has used a fair bit of language in setting out its vision for general practice, I'm sure deliberately, that aligns closely with what the government has promised. So there's also strong support for moving a bigger share of NHS funding into primary and community care from this government, something the Darcy report called for. These are factors, and there are plenty of them, that also provide some hope for a deal that can offer a brighter future for GPs.
You mentioned continuity there. We definitely know that that's something that's likely to feature a part of negotiations potentially for this year's contract. We could see something on that as soon as next year. Wes Streeting has already said he wants to introduce incentives for continuity. And at the Labour Party annual conference last month, Health Minister Stephen Kinnock said that continuity, as well as what happens to these GP ARRS roles, would be part of contract discussions this year. We're going to come on to talk about those GP roles a little bit later. And you also mentioned bureaucracy there. We know the government's really keen to do something on that sooner rather than later. This was something Wes Streeting talked about in his speech to the RCGP conference earlier this month. He talked about a red tape challenge that would be led by NHS England's primary care medical director, Dr. Claire Fuller, and the secondary care medical director, Dr. Stella Vig. So he wants doctors and other clinical staff to tell NHS England what is wasting their time, what needs to change, and pointless appointments they don't need to have, or things that, could change to free up clinicians' time. Certainly, a lot of that will be outside of the GP contract, but we could perhaps also see, maybe as soon as this year, some steps to streamline the QOF, and maybe that's where the government will be looking to find some money to incentivise continuity, if that's their key priority. So there could be some change on that soon, but we'd perhaps see even bigger changes in the QOF a bit further down the line if there is a wider overhaul of the contract, maybe even the end of the QOF perhaps as part of that. But Nick, one of the other things we know the government wants to do, which you mentioned, is this shift to a neighbourhood NHS. So this is all about moving services out of hospitals into the community. And, we think this is likely to be a pretty big feature in that 10-year NHS plan, which is due out next year. At the RCGP annual conference, Wes Streeting said the government wanted to start this massive engagement exercise with staff and patients about what the plan should look like. But we know that neighbourhood vision will be central to it. Will that need to involve GP contract reform, do you think?
It might do. A report from the NHS Confederation this month argued that creating a neighbourhood NHS would depend on significant reform to GP contracts and funding. Clearly, providers tend to do things when they're incentivised to do them. So creating this shift will be, at least in part, about creating the financial framework to push GP practices and other organisations in that direction. It's not entirely clear how contracts would need to change, though. At the moment, PCNs are funded through the network contract DES, and that's a contract that sits alongside the main GP contract. So the kind of reform the Confederation has in mind might be an overhaul of something like that, rather than a fundamental shift to core practice funding in some way. But the report it published suggested they might have more of a fundamental shift in mind. It said there was significant variation in practice's capacity to work in partnership with communities, and that to enable GPs to do this would require, and I quote, changes to how primary care services are contracted, funded and assured. We know that Labour's committed to a neighbourhood health service, and that this will form a big part, as you mentioned, of the 10-year plan for the NHS, and that's likely to be published early next year sometime. And we know too that in response to the Darcy review earlier this year, Keir Starmer promised what he called the biggest reimagining of our NHS since its birth. The Confederation said that there's still work to be done to define the right balance between what can be delivered by local systems and as part of a national NHS offer. So the idea of what might come under a neighbourhood NHS is still being worked out. But GPs will definitely have a key role to play, and that could mean changes to their contracts and funding, and those changes could be significant, but all that's still to come out in the wash.
Yeah, I mean, obviously, the other party that will be involved in contract negotiations is NHS England. And we can perhaps see some of the signs of the things that they're looking at with their view about where the GP contract should be going with these GP operating model pilots. I mean, we've talked about these on the podcast before, but we saw a bit more detail about how these pilots might work at the end of last month, including the names of the 22 primary care networks that are taking part in them. These pilots are quite controversial, and the BMA is really very opposed to them. It has basically asked practices not to engage with them as part of collective action while it explores other opportunities for changes to the GP contract with the government. But NHS England has said the results of these pilots will be used to inform Integrated Care Board and national strategies, including changes to the GP contract. So what are they looking at, and why does the BMA dislike them, I suppose? I think a lot of the BMA's objection to these pilots is that obviously they are looking at all of this at a PCN level. The BMA would argue, as you've talked about already, Nick, today, the BMA would argue that problems with the GP contract relate to underfunding and that we need to invest more money into core GP funding to allow practices to decide how best to deploy those resources to meet the needs of their patients. Well, these pilots are clearly aiming to look at everything at a network level. And then obviously any conclusions they draw will likely be based around network. Potentially the upshot of that could mean that more funding or any extra funding would be directed towards networks, as we've seen in recent years with the ARRS and the 5-year contract, as opposed to core funding. And there's all sorts of problems which we can see with that, and all sorts of reasons why the BMA would object to that. So the networks involved in these pilots are getting quite a bit of extra funding to do this. They're being paid for participating. They're getting money to increase their clinical workforce by 10%. So that's to effectively accelerate them, so their workforce reflects what it would be in 2028, 29 if it grew in line with levels set out in the NHS workforce plan. And they're going to get extra funding to do specific things that they try. So maybe taking on new digital tools or for communication with patients to explain the changes they've made. And Nick, you reported earlier in this year that these are pretty large sums of money we're talking about, 7-figure sums potentially by next year. And then a big part of what these pilots are looking at is basically access, and more specifically the gap between demand and capacity. And NHS England says its aim is really to gather data to give it a better understanding of that gap, what's causing it, and some possible solutions. So these pilots are going to be assessing the impact of loads of different interventions, which are things like introducing more digital tools, automation processes, proactive population health management, expanding uptake of the NHS app and Pharmacy First, boosting continuity potentially for some patients, and looking at problems around the primary and secondary care interface. And there'll be all sorts of audits going on alongside this, looking at how all of these things that they do impact on practices, on other parts of the health system, on patients, on staff. There'll be extra surveys going on of patients and staff. So, in some terms, it does all sound quite reasonable, doesn't it? It sounds like quite a good idea, trying to work out why is there a problem between demand and capacity? How can we fix it? But obviously, there are those BMA concerns I mentioned. And there's also always this problem, isn't there, with pilots? I mean, NHS England says that these are going to be used to inform contract negotiations. But what works in these primary care networks may not be things that work in every primary care network. I mean, these are networks that are probably already working very well together, already have a real shared vision. It's really unlikely networks not in that position would want to do this. But we know that not all PCNs are like that. And I'm sure, if NHS England is looking at these pilots, these ICBs are likely to be providing quite a lot of extra support to the PCNs and practices that are taking part to make sure they're a success. Would that happen if this was suddenly rolled out to all 1,200 odd PCNs across the country? Probably not. And so that's the problem with pilots like this. We can draw a lot of potential conclusions from them, but just because something works well in one area or one situation, it doesn't necessarily follow that it will then work everywhere. But anyway, on saying all that, I think it will be interesting to see what the results from these pilots start to show, because they could very well find some solutions to some of the problems practices are facing. But whether or not that means any of this should actually be added into the GP contract or made a contractual requirement is perhaps the issue that's more concerning for GPs. But anyway, speaking about PCNs, it's probably also worth talking a little bit about GPs being added to the additional roles reimbursement scheme as well as part of this. So that all happened at the start of this month. And there's been some concern about how all that's going to work, hasn't there, Nick?
There has. GPs haven't been convinced from the start that creating jobs for GPs via the ARRS is the right way to go. Clearly, there's a need to create jobs because, as we've reported over the past year or so, thousands of qualified GPs have been struggling to find work because practices can't afford to recruit, despite the fact that workload is off the scale. Some of the main reservations GPs had involved concerns that hiring GPs through PCNs would deny them the support they'd have from working with a specific practice and the ability to build a relationship with patients in one place, for example. So it goes against this idea of continuity of care that we've been talking about as a priority not only of the BMA but of the current government. But there have been practical concerns too. A lot of concern that the rates of pay on offer are not enough now that we've seen them, and that details of the funding for GP ARRS roles were actually only published days before the scheme was meant to start. So we wrote a story sometime in September, at the beginning of September, I think, saying that it would be impossible for PCNs to recruit doctors through the ARRS because of the short timescale. GPs found out only at the end of September how much money PCNs could claim for these roles, despite the fact that the jobs were actually supposed to start from the 1st of October. So clearly it was impossible to recruit at such short notice. So GP ARRS jobs won't run for a full 6 months of the current financial year, which was apparently the plan initially. One positive in this is that Wes Streeting confirmed at the RCGP conference that funding for these roles would not stop at the end of March 2025. And that addresses a really big concern for general practice, that basically because the funding had only been guaranteed for that time-limited period of 6 months, the jobs might just evaporate at the end of that time.
You were at the Best Practice event in Birmingham last week, where NHS England's National Director for Primary Care and Community Services, Dr. Amanda Doyle, was speaking. And she also had something to say about GPs being added to the ARRS, didn't she?
Yeah, so she said that the ARRS may not be the best solution long-term to creating extra GP jobs. So that's potentially a message that GPs will be quite happy to hear. Pretty much any GP in the country could have told her that the ARRS was not the long-term solution creating GP jobs. But the fact it came from such a senior figure in NHS England is interesting. And she said one of the reasons the government and NHS England didn't announce funding beyond 6 months right from the outset was because they didn't want to give the impression that these jobs would stay in the ARS forever. So there's a hint that something could change. And the point she's making is that there's still an active discussion going on about what the future of those jobs is. And she said too that work will begin in earnest to define the future for these jobs beyond March 2025 once the NHS knows its funding situation for the year ahead. Once the government's published its budget, which is coming at the end of this month, then the NHS will be counting its pennies and working out, what money it's got available to fund any part of the NHS system, and deciding at that point how much of it can allocate to GPARS jobs or a version of those jobs funded through a different mechanism down the line. Emma, one thing you also want to talk about was assisted dying in light of the new bill that's been introduced to Parliament in Westminster this week.
Yeah, so this bill's been introduced this week, and it's proposing a change in the law to allow assisted dying, and MPs are expected to debate this and hold a first vote on the bill on November the 29th. So I think we're going to see a lot of debate around assisted dying in the press and the media over the coming weeks as both sides of this issue seek to influence MPs ahead of that vote. Full details of the proposed legislation may not be set out until closer to that debate at the end of November, but the MP who's proposing this bill, Kem Leadbeater, she said that there will be safeguards in place and it will be specifically aimed at terminally ill adults. There's been numerous reports about what it will probably contain. It looks likely it will involve 2 doctors needing to approve the patient's decision, that patients will have to be mentally competent, and it seems probably likely that the drugs that will end someone's life will have to be self-administered. So these sorts of safeguards are very similar to those that are in a bill that's being considered in Scotland at the moment. There's also a bill proceeding through the Parliament on the Isle of Man, which could well make assisted dying available to residents there from 2027. These will be people who are mentally competent and have less than 12 months to live. And Jersey is also progressing with plans to legalise assisted dying, which could also happen from 2027. And I expect as plans progress in all of these regions, any change in the law would also be accompanied by guidance making it clear that doctors won't have to be involved with this if they chose not to. But obviously, those are details that would be coming out sort of after it goes through that process. So obviously we're talking about this because if the law does change, it will have pretty big ramifications for general practice. Even if doctors aren't involved with signing off an assisted death, they will potentially, have patients coming to them wanting to talk to them about this. And this is an issue that really does divide the medical profession. There's been a shift among doctors about assisted dying over the past decade or so. Many medical organisations, including the BMA and the Royal College of Physicians, have changed their stance and moved from being opposed to assisted dying to adopting a neutral position, although quite significantly the Royal College of GPs remains opposed to assisted dying. But I think it's fair to say a significant number of doctors really do oppose assisted dying, but that opinion is starting to shift towards more of them being more supportive of it perhaps than they were in the past. But this is obviously a really complex and difficult issue and not something we can really get into in a short section of this podcast. But if people are interested in hearing more about this and what GPs think, I would urge them to have a listen to a special podcast we did last year about assisted dying in Scotland. In that I spoke to GPs, politicians and patients there to look at their views and some of the potential challenges a change in the law could bring. And obviously, many of those issues will be relevant to the bill that's due to be debated in Westminster. So do have a listen if you're interested in a more nuanced discussion about some of the issues at play here. We'll put a link to that in the show notes. So there's been quite a lot of developments around physician associates since we last spoke on the podcast, so we thought it was worth rounding some of that up. So last month, the Royal College of GPs held a council meeting where it was due to discuss new guidance it had produced about physician associates working in general practice. We talked on the podcast before about the RCGP calling for a halt to recruiting any new physician associates in general practice back in June, after a consultation it carried out with more than 5,000 of its members raised concerns about patient safety. In response to that, the college decided it needed to produce guidance on scope of practice for PAs in general practice, supervision and induction and preceptorship. But at the meeting last month, where those 3 bits of guidance were due to be discussed, the council actually then decided to vote on whether there was a role for PAs at all in general practice. So up until that point, the college's position was that there was a role for PAs in general practice, providing they were adequately supervised and supported. But during that meeting, 61% of college council members voted to oppose any role for PAs working in general practice. And as a result of that, the college has now changed its position to back that point of view. However, the college said at the time of that vote that as there are around an estimated 2,000 PAs already working in general practice, mostly in England, it would still continue its work producing those 3 pieces of guidance, and those bits of guidance were published last week. So Nick, first off, the scope of practice guidance it's quite significant, isn't it? It really restricts what the college says PAs should be doing in general practice. What exactly does it say?
The limits the RCGP has set on what PAs should be allowed to do are really, really tight. The guidance says the scope of practice for PAs that is described in the guidance is deliberately narrow. It says that's because the most important consideration is patient safety, and basically because there's limited evidence around the effectiveness and safety of PAs. Much like previous guidance from the BMA, it says PAs should never see undifferentiated patients. So this emphasises again that the role initially envisaged for PAs by NHS England is simply not workable in the college's view. The guidance says PAs should only see patients who've been triaged by a GP and only undertake work delegated to them by and agreed with their GP clinical supervisor. It says that practices can ask PAs to take a history, complete a physical examination, and construct an appropriate diagnostic and management plan, and that they should share that contemporaneously with their GP supervisor or potentially at the end of a session if they're more experienced. But it says PAs should never be triaged presentations for potentially serious conditions or for patients with suspected mental illness, patients aged under 16, women who are pregnant or postnatal or who have a suspected gynecological condition. They should also never be delegated management of patients with complex multimorbidities, complex or rare illnesses, or severe frailty, and they shouldn't be asked to carry out urgent or routine visits to patients' homes or in care homes, must not initiate or complete end-of-life discussions with patients, and must not see patients with learning difficulties. There are also limits around clinical procedures and tests, reminders that PAs cannot prescribe or cancel existing prescriptions without approval from their GP supervisor, that they can't complete fit notes, child protection forms or cremation forms, and should never be responsible for debriefing after a patient contact, or be asked to teach, supervise, or undertake debriefs for GP registrars or medical students. It's a pretty exhaustive list.
It is a very restricted role the college believes is safe for PAs to carry out, isn't it? So the other bits of guidance cover supervision, and there's one on induction and preceptorship. The supervision guidance is pretty clear that PAs need a lot of supervision. So this is something practices are going to have to really consider. Basically, it says PAs must have a named GP clinical supervisor and always work under the supervision of that doctor, although that can be delegated to another GP if that doctor is away or out of the practice. They should also have an educational supervisor who's responsible for making sure they have the training and ongoing education they need. That might be the same doctor, but it could be a GP who takes on that role across the PCN for all of the PAs perhaps. Both of those doctors need to be trained in supervision. And the RCGP says there needs to be protected time in the clinical supervisor and PA's job plans for supervision, and that PAs need daily supervision to review all the cases from that day. They also need a weekly or fortnightly review. Any notes made by a PA need to be signed off. In a patient notes, they need to be signed off by the GP clinical supervisor at the end of the day as well. So there's quite a lot there. And then the induction and preceptorship guidance, meanwhile, says that all PAs should have a proper induction every time they start a new practice. If they're new to general practice, they should take part in a year-long preceptorship programme, and they need a structured educational plan in place. Key to both of those bits of guidance and the scope of practice, I think, is that patients should always know that they are seeing a PA. That's made really clear across all of those RCGP bits of guidance. And also that everyone in the practice team is really clear on what the PA role is and what they can and can't do. So Nick, taken all of that together, what does this mean for practices employing PAs, do we think?
It's a really big list of things that the RCGP believes PAs shouldn't be doing in general practice. And ultimately, it simply rules out a lot of the work that takes place in general practice as something that PAs should be involved in. And it means that the way many practices have been using PAs in recent years, often in line with the kind of vision that NHS England set out initially in 2019 or so, is going to have to change.
Some of the developments with PAs in recent weeks are also that the GMC has confirmed the date it will start regulating PAs. So from the 16th of December, physicians associates and anaesthesia associates will be invited to register with the GMC, although they won't be legally required to do so for a further 2 years. I mean, the GMC says regulation is a vital step towards strengthening patient safety and public trust in those roles, and will help assure patients, employers and colleagues that PAs and AAs have the right level of education and training and can be held account if concerns are raised. But obviously we know there's lots of concerns about GMC regulating PAs, and there's also been some more developments on that. The BMA's thrown its weight behind a legal challenge to GMC regulation that's being crowdfunded by a campaigning group called Anaesthetists United. That legal challenge is arguing that the GMC has failed to properly distinguish between doctors and PAs and AAs because it hasn't enforced a national scope of practice for those roles. And the BMA's basically said it's going to provide some indemnity for any adverse legal costs that group incurs at certain stages of the case, which could mean that they may have to pay GMC costs if the case is unsuccessful. And the BMA is also continuing its own legal challenge against the GMC. Its case argues that the GMC shouldn't be allowed to use the term medical professionals to group together doctors and PAs and AAs, which it is currently doing, because it's confusing. So obviously we need to wait and see where both of those cases go. So just finally, we've got time for our good news story. There's actually been a few good news stories around over the past couple of weeks. I discussed Wes Streeting's pledge to merge the GP and specialist registers on one of our special podcasts from the RCGP conference a couple of weeks ago. But that's definitely worth mentioning again because it is a really positive step in terms of recognising the expertise of GPs. It's also something that GPs have been calling for many years as well. In those special podcasts, we also mentioned the RCGP Marie Curie Daffodil Awards, which recognises practices and GPs who are providing excellent end-of-life care. The winners of those awards were announced at the end of the conference, so you can find out more about them on our website, and we'll put the link to that in the notes for this episode. But another good news story that's worth flagging this week is a story Nick wrote about patients' experiences of contacting their practice. What's that all about, Nick?
So this is about findings from a health insights survey that the Office for National Statistics has been carrying out over the past few months. It's run this twice so far, once in late July and early August, and then again in late August to early September. And it found an encouraging rise in numbers of patients who say it's easy to contact their GP practice between those two periods. And that's a welcome turnaround from some of the criticism practices have faced in recent years and months. So based on polling of around 100,000 people, 67% said contacting their practice was easy in the more recent survey, compared with 61% in the previous one. So it's a 6 percentage point jump in the past few months. The survey actually looks at multiple ways of contacting GPs and found that patients reported it was easy across the board for the different types of contact, whether it's by phone or online or whatever. And just as a longer-term benchmark, the latest annual GP patient survey, that's something that's carried out in the first 3 months of each year, found that just under half of patients said it was easy to contact their practice by phone. And looking specifically at that measure in the ONS survey, it found that figure's risen now to more than 62%, so it's a really big jump. And Amanda Doyle, the GP you mentioned earlier, who's NHS England's Primary and Community Services Director, she said that this was basically a sign of the green shoots of recovery, so really positive for general practice and how it's tackling some of the problems and the criticism that it's had around access.
Well, that's it for this week. Thanks to Nick, and thanks so much for listening. I'll be back next week, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice on our website at GPonline.com.